Welcome, everybody. I am so glad that you're here. We are going to be talking about perimenopause and menopause and hopefully answering some questions that you might have. I do have some questions that I brought to the webinar myself, but I'm hoping that you will write down in the chat box anything that you're wondering about, or if anything comes up, you just write it down there as well. And I hope that I'll be able to read that and it's successful. So before we really dive into the questions, there are some people who have registered who don't know me. So I'm going to introduce myself. So I'm Cindy Dupuy. I've been in the functional medicine space for about 20 years. And I've been helping both men and women navigate the healthcare, their health, and the problems that they come to see me with where they haven't been helped by the general medical society here. So I help them with digestion, with thyroid, with weight gain, and all of that. And I moved into the perimenopause and menopause space about 7 years ago, and it came out of two different impetuses. And one was the fact that I was watching my clients who had been with me for a while, and I knew how they ate, I knew their lifestyle, I knew that they were in pretty good shape as far as that was concerned, but they were still losing some ground. So I had to kind of scratch my head and say, okay, we're missing something here. And then I also, I've been in menopause myself for about 25 years. I did go into it a little bit early at age 43. And I've been watching my contemporaries lose ground as well. So they're becoming much less mobile, having a lot more aches and pains, and the doctors a lot more, and taking a lot more medication. So that was an issue as well. So I jumped into the world of hormone replacement. I had been on hormone replacement myself for about 15 of the almost 25 years I've been in menopause. And I really felt like it did make a difference. So I did a deep dive and became a meta coach, meta guide, and I am here kind of on a mission. And I know there's a lot of the people in this space as well, but on a mission to help as many women as I can to navigate this time with ease and with vitality. And it's a very personal decision what you do during this time, but I want women to have the knowledge so they can make the choices that they need to make for themselves and ask for what they want and ask for what they need. So basically being advocates for themselves. Before I jump into any questions that you might have and the questions that I've brought as well that have, come to me over the years from my clients, I am going to just talk in general broad terms about perimenopause and menopause. Basically perimenopause, right? It typically happens between the ages of about 40 to 50. The average age of going into menopause is about 51. And it's a time where it's kind of a roller coaster. And some people coin it as a second puberty because in puberty, when the hormones start to come on board here, they can be all over the place. The periods can be all over the place. The moods can be all over the place. And that is our bodies trying to just know what to do with the hormones. And the exact opposite is happening as we start to go into perimenopause, when we start losing those hormones and our bodies have surges and stops and starts. And so it's not necessarily a fun time. So I'm going to talk specifically about some of the signs and symptoms that we'll see during perimenopause. And I put perimenopause and menopause because some of these symptoms can roll into menopause as well. They might not be felt as strongly. And some of them, of course, cycle changes, we're not going to feel those when we're in menopause, right? So in perimenopause, what we're going to start seeing are cycle changes, irregular and skipped periods, often heavier, sometimes lighter, shorter, all of that. Vasomotor changes. So we'll have hot flashes, we'll have night sweats. This is often seen, and they can be intermittent as well. And some women suffer more from that than others. And then we can have sleeping issues. We have trouble falling asleep and then staying asleep. And sometimes this is tied to night sweats, but it can also be tied to a drop in progesterone, which is the hormone that drops first in perimenopause. And then we can have mood and cognition issues. So we can feel more irritable, we can feel more anxious, we can feel more depressed or depressed for the first time in our lives. Brain fog can be a huge issue. And forgetfulness as well. So you walk into a room and go, oh, why am I here? Or we can't do that word retrieval, or we've lost a thought, a train of thought, which can be limiting and a little embarrassing, and sometimes even compromising if we're giving a meeting or we're in a space where we really do need to be able to pull that all in and utilize our brain power. We can experience physical changes, so we can have more breast tenderness, we can have more bloating, we can have that weight shift to more of that meadow body or that meadow belly. It usually doesn't happen quite until menopause, but it depends on the woman. And then we can have hair and skin changes as well. So we can have drier skin, we can have more oily skin, we can have hair that's losing, become drier. And then we have the sexual and urogenital changes. So we can have a much drier vagina. And those are more early signs. And then a reduced libido, definitely, especially as estrogen starts to drop. And then if we're not really prone to UTIs, maybe all of a sudden we are prone to UTIs, or we have a bunch of them if we've been prone to them in the past. So that's the whole changing of the tissue around the urogenital area. And then other things that some people don't think about that are also associated with perimenopause is fatigue, joint pain, and aches, headaches, worsening PMS, allergy increase. Okay, so that's the fluctuation of the hormones as well, and increased facial hair. And what's happening there is that as our estrogen starts to drop, our testosterone actually, for the most part, stays about level. I think a lot of people think we have a huge drop in testosterone. We really don't. And so that imbalance can have a little more facial hairs around the chin and maybe around the mustache area. And then we can lose some of our hair. So it's just a shift and maybe a little bit of an imbalance there that sometimes corrects itself. So then we move into menopause, right? We get to that finish line and you've arrived. And that finish line is kind of arbitrary. I don't know who came up with it. And it's a finish line where, after a year of not having any menses, you're all of a sudden in perimenopause. Now, some women think that if you haven't had a period for 6 months or 8 months and have your period, that you have to start all over again from counting for the 12 months. That's not true. I mean, if you really want to know, you can test two different hormones, LH, which is your luteinizing hormone, and your FSH, which is your follicle stimulating hormone. And both of those will rise precipitously as we move into menopause. So, I mean, that's something you can do, or just know that you're in menopause. In some, in the background on this one, you can see barely, there's what people on a roller coaster ride. And one woman is just laughing and having a great time. And then the other woman is like, oh my God, get me off of this ride. And that's how it is for some women. Some women move through perimenopause and menopause without feeling a whole lot. And, I was kind of one of those, but also, I moved in from having my periods to not have my periods in like maybe a 2 or 3 month period. And it is different for everybody. So the women that don't really feel it, yay. But the women that do feel it, we need help, right? We need to understand, we need support. So sometimes we can be moving into that menopause space feeling pretty frazzled and frumpy and fat, especially if we are not on HRT, okay? To kind of mitigate a lot of the things that happen once we lose our estrogen and our progesterone. So here are the symptoms of menopause. And again, I put perimenopause and menopause because they can kind of move from one to the other. And even though as we move into menopause, that roller coaster ride usually abates because we don't have any more of those ups and down and hormone, going up and down fluctuations, and things get a little bit more stable. We're still going to experience some things. So we can still have hot flashes. We can still have night sweats, often much less. We can still definitely have steep sleep disturbances, so insomnia. We can still have mood swings. They may have stabilized a little bit, but because again, we're not having that huge fluctuation in estrogen, but brain fog and memory issues can still persist. And I know that when I back down on my hormones, my memory and my recall of names and things like that, it comes back just like that. Vaginal dryness, no question. Painful intercourse, no question, because that whole tissue around that area has atrophied and it's become dry. Estrogen has a huge role in producing collagen, and it also has a role in pH. So bacteria and urinary tract infections again can increase. I have seen some women that have been treated time and time again for UTIs. And so a lot of antibiotics, right? And really all they needed was some vaginal estrogen to help negate that. And it's just a travesty that they aren't offered that. Some women experience more urinary leakage and urgency. Some women don't. I'm one that does when I don't have enough estrogen on board. We can have that wonderful, right? Belly that comes forward. And there's reasons for that. There's many, many reasons for that. There's increased inflammation. Our bodies want estrogen. And so our fat is one way that our body makes more estrogen. So it's kind of a catch to it. It's not something that we can get into in depth here. It is something I get into depth when I have a course, it's an 8-week course. It's called Women of a Certain Age. And I'll talk more about that a little bit farther on. But there's reasons for this. There's some things that we can do about it. We also will start experiencing more muscle loss. This is really, really important. I know that most people think of estrogen or testosterone as maintaining your muscle, but estrogen plays a huge role in that. Metabolism will slow down as well. Long-term health. So we really start thinking about long-term health about this time. So we can have accelerated bone loss, we can have higher cholesterol, increased heart disease risk, Alzheimer's, dementia as well. So that's a little bit more on down the road for most women, but it actually starts before perimenopause. Other things that I think a lot of women and doctors as well, healthcare professionals don't put together as this is, part of menopause. So thinning hair, dry skin, brittle nails, joint stiffness and pain, increased digestive issues. Can have ringing ears, itchy ears, ghost smells, metal taste, heart palpitations, and frozen shoulders. So I don't know if you guys all know that this is part of this whole wonderful phase, but these are symptoms. And yes, you can treat a lot of these with pharmaceutical drugs, but then we start reaching into polypharma, which I'm not a fan of. So I want to talk a little bit more about menopause. And, in my opinion, it's basically, we have two different phases of menopause. We have that first phase where, around 51 to about 62 to 65. And that's kind of but I actually, if you're supported, you're doing a lot of things right, especially if you're on HRT, this can be really wonderful years. You can still feel very big and powerful. You're still building muscle. You're able to do that fairly well. Often you become empty nesters, and all of a sudden you can focus on yourselves. So I know personally that between the ages of 45 and let's say 63, for me, I think I felt like I was on top of the world, that I could do anything. And then it shifted a little bit, and it shifts into a more mature menopause, maybe you could call it that. And it's a shift on an emotional and a physical level. It's a wonderful place to be in so many ways, but it's also a time where we start seeing the diseases of aging, okay, really start coming in. So it's a time for concern as well. I think we realize that, we probably only have about 2 decades at this point in time in the second part of menopause, 1 to 2 decades more of living. And so we really kind of take stock of our lives. And I don't know, I think more love and more joy can come in during this time of our life. So it's a totally different place to be in. I want to talk about bones for just a second before I go back to your questions. And the reason why I want to talk about bones is that it's something that's been on my radar a lot lately. And we lose the most amount of bone in the first 6 to 7 years of menopause, all right, rapidly. And it is the loss of the estrogen. And estrogen prevents our osteoclasts, which are the cells that break bone down. So estrogen will slow that bone breakage down. And the thing that really, really gets me is that estrogen replacement is approved by the FDA specifically for preventing osteoporosis. I don't know very many doctors that, number one, will test their clients with a DEXA scan to see where their bone mass is at the beginning of menopause. And they often don't test it till a woman is in her 60, 65, where usually we already will see if she has risk factors. She's already already has osteoporosis. So this is something that I want women to really pay attention to ask their doctors to do it. There's risk factors involved. I've got a whole couple different blog posts on that. So you can see the risk factors and learn how to talk to your doctor about the risk factors. You can pay for it out of pocket as well. I think depending on the state that you're in, it can cost, I don't know, probably average around $200. Now, I know that body composition also is a DEXA scan. You need to make sure it's a DEXA scan that specifically looks at bone and gives you a T-score. So yes, the majority of our bone loss happens in the first 6-7 years of menopause, and most women are not tested for bone mineral density until their 60s, which is too late. Okay, so that's what I want to say on that. All right. Now, I've already mentioned HRT myself. I take it. I think it's important, and we'll be talking probably some of the questions that you have will be regarding HRT. There'll probably be other questions as well. But I want to make it very, very clear that HRT is not the end all be all ever. And I really have an issue with anti-aging clinics. I have an issue as well with, the online companies that provide women with hormones like Alloy, Nitty. There's another one out there too. And I mean, there's a reason why these online companies are there. It's because women can't get help from their doctors. So I'm glad they're there on one hand. It's big business as well. But what they're missing is that all of these other things it's the terrain. We have to make sure that the terrain is in good working order before we put HRT on top of it. It's like, to me, a doctor throwing a pharmaceutical at a person without addressing nutrition or lifestyle or gut health or environment or adrenal or thyroid health, which is super important. All 5 of these are important. All 5 of these, plus lab work, plus hormones. We go into in depth in my Women of a Certain Age Grace and Transition course. So I'm going to stop sharing here. I'm going to see if you were able to put anything in the chat box. I'm not seeing anything here. So it's either my technical error here, or you guys don't have questions, or I'm not quite sure. But anyway, I am going to go ahead and jump in with some questions or some situations that have come through my clinical practice that I also see on social media as well. So I'm going to try this one more time, guys. Okay. Okay. Thank you, Christine. Christine says that the chat says it's disabled, so use the Q&A box. So please use the Q&A box. Thank you, Christine. She's so good. So the first one I'm going to bring up here has come in. My doctor is worried about giving me estrogen because of a history of stroke in my family. So she doesn't want to do estrogen, but she wants to put me on testosterone instead. And what are my thoughts? Okay. It's a very outdated mindset that estrogen causes strokes. It does not. It's actually very heart protective. And we know that one of the reasons why we know that is that women do not really have an issue with cardiovascular disease until they move into menopause. And then the rate of death for women outranks the rate of death from cardiovascular disease of men once a woman is in menopause. So where it comes from is that, oral estrogen, whether it's bioidentical or non-bioidentical, okay, passes through the liver, has to pass through the liver, and it is turned into a more inflammatory type of estrogen, okay, is turned into estrone. So there's 3 different types of estrogens that our bodies make. And it's something, again, that we go into in my course because we need to know that in order to navigate everything that's out there, everything that we hear. But anyway, it's turned more into the inflammatory form of estradiol. So no, I wouldn't recommend having estrogen orally, but transdermally. It does not do that, doesn't have that inflammatory effect. So I think she has been misguided a bit and maybe more on the old dogma from the Women's Health Initiative study. The other thing is that, I'm happy she's trying to do something for her client. She cares for her client, obviously. She didn't just shut her down. She's coming up with some different things. As some doctors, they think if you give testosterone, our bodies do convert testosterone into estrogen, but not to the degree that we actually need it for all the protective things that estrogen does. So she's not going to get the benefit of just taking testosterone and maybe some progesterone as well. She might get some, but it's not going to be as big of a benefit. And I don't think that she has to be afraid of taking transdermal estrogen. All right. Christine, what are my thoughts about women with a history of cancer and HRT? All right. That's a big one. So if a woman herself has had, let's say, breast or uterine cancer, right? And I'm assuming that's what you're talking about here, or ovarian cancer, right? I would say it's really important for a woman to understand the risks of taking bioidentical hormones transdermally and not taking bioidentical hormones transdermally or progesterone orally. Okay, but I'm talking about estrogen transdermally. And there's other ways of taking estrogen as well. You can do injection, you can also do pellets. But I think she needs to know and weigh the risks for herself. And she also needs to weigh what her quality of life is for her now and where she's at on that continuum. Does estrogen cause cancer? The answer is no, it does not cause cancer. There's been studies that have come out, even one just very recently. It was like a million women study. And basically, what it was is gathering information from Medicare women, so everyone 65 and older, right? And it came back that it actually caused less cancer. So there aren't really any good studies yet out to see if taking estrogen or hormone replacement increases or decreases the risk of cancer returning in a woman. There aren't any big studies. Now, the UK is far ahead of us when it comes to hormone replacement. And there is this big study that they are putting together and they're gathering their information, right? So they have the type of system where everything is in one place, it's social medicine, so they can get a lot of information. It'll take years before it comes back. So estrogen does not cause cancer. Progesterone does not cause cancer. Testosterone does not cause cancer. Now, if you're in the throes, cancer and perhaps cancer treatment, estrogen is probably not going to be a good thing to do here. All right. And if there's cancer, a history of cancer in your family, but you don't have it, I hear doctors say, I don't want to put you on it. That's your family. We have no idea what their lifestyle is. And there's plenty of women who get cancer who've never had a family history of it. So that doesn't determine one way or the other. So I hope that answered that question. If you have any further questions, on top of that, I got one from Sharon. I'm going to read this out loud. I'm 11 years out from last period and 65 years old. I don't do HRT because my mom died of ovarian cancer. Now I wish I had due to bone loss, itchy ears, thinning hair, etc. Many say it's too late to start HRT. Others say it's okay. I'm concerned about possible increase of dementia as I start HRT at this late age, from what I read. I've been on raloxifene, which may be stopping my bone loss. I've read about collagen peptides that can help with bones too. Okay, there's a lot to unpack here. Okay, I think I already unpacked the first part, and that is just because your mom died of ovarian cancer does not mean that you are not eligible for HRT, that you were not eligible for HRT. Unfortunately, there are 2 to 3 decades of women, and I fall in that era, you do too, where, that Women's Health Initiative, the results of that had just come out. And there's just decades of women, we're at 65 or older. And now doctors will say, no, I can't put you on HRT because you're too old. So we have that. It's like, we're damned if we do, damned if we don't, right? We had it coming and going both ways. It's not too late to start. I know what you're referring to as far as dementia. There was some study or article that came out that was misquoted, I would say, and I can't even name what it was. It does not cause dementia. It does not cause Alzheimer's by any stretch of the imagination. Okay. It helps with both of them, actually. It's not too late to start HRT. The hard part is to find a healthcare provider who will prescribe HRT to you. I do think one or two of the online providers will do that for 65 and older. Some of my clientele are like I have one lady, I love her to pieces. She's 85 And she went on HRT and low dose, I would say start, fairly low and kind of work up, see how you feel. There's a lot of some women go right into HRT and they're fine. They find their lane really, really quickly. Sometimes we have to kind of what's the word I want? See, word less here. We have to kind of navigate it, okay, and fine tune it. Anyway, she loved it. Okay. She loved how she felt. Her aches and pains were reduced. It was like she's got her life back. That's how she felt. I have another woman, 73, a lot of bone pain, osteoporosis. Also, she's on Prolia, which can definitely cause jaw, bone loss, necrosis of the jaw, which is devastating. It's absolutely devastating. Okay, so if anyone has osteoporosis, I'm like, let's get you on estrogen. Is it going to reverse everything? No, it's not going to reverse everything, but it's probably going to be able to prevent, other things from happening. Of course, you still have to have your diet. You have to have your gut working. You have to look at your environmental toxins. You still have to have all of that, your inflammatory markers, all of those things dialed in as well. Okay. But it's not too late to take it. I do have some providers that will give it to women who are, 60, 65 and older, 10 years out. By the way, with that bone health again, the Prolia, both the Prolia and the biphosphonates, while they will prevent the bone loss, the quality of bone does not necessarily improve or increase, and that there's often a spontaneous break or fracture in the femur, which is right there by the hip. And so the medications that we were taking to prevent a broken hip supposedly can actually still cause a fracture in a major bone. And the reason why this is really important, and I meant to say this with the bone slide, is that, we think a broken hip, no big deal, right? We get a new hip, we're ready to go. The problem is that women who are 70 and older, once they have that broken hip, usually they don't get their mobility back, partially because they've lost so much muscle integrity and mass while they've been recovering. That's one. Number two is with that mobility, immobility in the initial part of it, what can also happen is a lot of women, like 20 to 30%, 70 and older, will pass in the first year after a hip fracture. And it's from raging UTIs or kidney problems or pneumonia or something like that. So it's not directly associated with the hip fracture, but it's the complications from that. So that's why bone health is so, so, so important. And Sharon, there's a ton that you can do. And if you haven't listened to Dr. Doug Lucas on YouTube, I don't think he has a podcast, he probably does. But anyway, he's actually pretty good. And I highly recommend you listening to him. And I think that you will find a lot of help and hope from him. And we do go into this again in my course as well. Okay, great questions. And let's see. Okay, why has my cholesterol gone up all of a sudden? We'll see that in perimenopause and menopause. Our bodies are super intelligent, and we still want estrogen. Our bodies do. So it does whatever it can, even though our ovaries have shut down the production of them. We still are making some estrogen, and our adrenals, small amount. But we are also making estrogen, and cholesterol is the backbone of our estrogen, of our hormones in general. Okay, so we have to have adequate amounts of cholesterol in order to make hormones. And so our body's going to go, hey, let's crank this up. So that's one reason why the cholesterol will go up. The other reason, two other reasons actually, that'll go up is as inflammation in our body goes up, LDL, the bad cholesterol, will also go up. And then if we are having an issue with our thyroid, hypothyroidism, and most doctors do not catch that because they are not doing a full thyroid panel on a woman. And it's something I see every single day in my clinic, unfortunately. But that will also cause cholesterol to rise. So those are three reasons why it'll rise. Do not panic about it. Do not allow yourselves to be put on a statin unless you've thoroughly done your blood work, which includes all the inflammatory markers. Make sure you do that first. Okay? I'm more interested and more concerned about inflammation in your body than I am about cholesterol. And also do a calcium scan where they're actually looking to see if there's any blockages. If there is any blockages and your inflammatory markers are pretty good, or if they're not, we can start working on them. We do that before we take a statin. Statins only help a very, very, very small percentage of the population from dying from cardiovascular disease. Estrogen will help way more than the statin will. Your lifestyle will help way more than the statins will. And there's a lot of side effects and risks by taking a statin. So that's cholesterol. Don't let your doctor talk you into it. When is a good time to start HRT? For some women in perimenopause, it's a good time to start HRT. Especially progesterone, but sometimes estrogen as well. And if a woman's really struggling with moods and things like that, and it's just quality of life is really becoming a challenge, I would say probably putting just a little bit of estrogen in to kind of smooth things out, the ups and downs and all of that might be something that she might want to do. I kind of cringe a little bit at the 35-year-olds that are saying they're in perimenopause, and I'm seeing that on social media all the time. And I'm not saying that they're not experiencing symptoms, because they are, all right? But just to throw hormones on top of a 35-year-old, anyone younger than 40 or maybe even 42, okay, just to throw that on top of them is missing a huge opportunity to really finding out why she's experiencing this, maybe why she's experienced some ovarian, shutdown. Is it because of thyroid? Is it because of environmental toxins, which is a huge one? Is it because there is also something going on with her adrenals? What's her diet and lifestyle like? So just to throw estrogen on a woman and she'll feel better, okay? She'll be happy, the doctors will be happy, but we're missing a huge opportunity to really help her on a very deep and level that's underneath that will help her throughout her entire life. Okay, so I don't think at the very beginnings of perimenopause that's a time to do it. There is a really nice maca out there. It's by Symphony Maca, and they make 3 different types of maca blends. And I find I use that on my perimenopausal women, and usually I can get them through to maybe squeak it out the last 2 or 3 years, and then we have to go perhaps hormones. So it can be in perimenopause, bottom line. Okay. Where are we on time here? Alrighty. Why has my libido gone away? It's gone away because your estrogen's gone away. So part of it is the tissue, part of it is, a lot of people think of testosterone as being our libido hormone. But if you think about it, you think about when we were menstruating, when we were fertile, that we kind of, at least once a month, we're probably jumping on our partners. And that was when we were ovulating. That was when our estrogen was at its highest. So as the estrogen starts to go down, that whole libido thing goes down. And part of that too is that estrogen plays a role in nitric oxide. And nitric oxide can play a role in high blood pressure, right? And it also plays a role in blood being able to get to the extremities, so down to the vaginal area. So that's a couple different reasons why we will start losing our libido. It's on a lot of different levels. Part of it physiological. Part of it is, if we've lost our estrogen and we're feeling depressed or anxious, that will also play a role in it as well. And as we're talking about libido, some women go, well, what happened to my orgasms, right? Where'd they go? Why is it so hard? Again, it's the estrogen, and it could be a little bit of testosterone. I do like to start my women on estrogen and progesterone first before we throw in testosterone, just to see how far we can go. But some women need just a little bit of testosterone just to bring things back to normal. And I do want to say this, and that is so many practitioners and definitely online companies as well, they are usually prescribing kind of the lowest amount of hormones, and progesterone in particular. We might be getting rid of the hot flashes. We might be sleeping a little bit better, but we're not really doing enough to prevent the old age diseases from coming on and from really having our libido and our sexual health really being to the level that we would like to see it at. And if you have a doctor who is not testing your hormones once you are on hormone replacement therapy, then I am guessing that they are not giving you that much hormones where they don't feel like they need to test it. My personal opinion, and the opinion of a lot of other doctors and healthcare professionals who know the menopause space and hormone space very well, will say that if you're giving adequate amounts of estrogen and progesterone, and if you're doing testosterone as well, that you need to be doing lab work to make sure it's in a good range. And something here again that we talk about a lot in My course, we go over all of that. I also go over, I'm going to mention this. Now, if there is cancer in your family, breast cancer, ovarian cancer, and you are wondering if maybe you have a higher risk factor, right? So diet, lifestyles, and environmental factors are the biggest things out there, really, and stress. So it's a lot. But some people, they have a pathway where their hormones go down, and you can measure this. And I know some people do the BRCA gene and they measure that. And if it was me, I would rather do a test called the Dutch test. I know I'm going off into a whole nother different thing, but it measures the urine metabolites or your hormones and also measures some of the nutrients that you have as well. And the metabolites show us the pathway that your body utilizes to break down and utilize your hormones. And it'll show us whether or not it goes down a more inflammatory pathway, a more cancerous possibly pathway or not. And there's some things that we can do about it. So if you're worried yourself about what your body does with hormones, and if you're not currently menstruating or currently not on hormone replacement, I wouldn't bother with this test because there's not a whole lot to measure, right? But if you are and you want to see, I highly recommend that. And it's something that I offer. Okay. I am going to go back real quickly to talk just a little bit about my 8-week course, maybe. Again, it's called Women of a Certain Age, Grace in Transition. I'm super excited about it. It is, it's an online course, but it's also a course where we have community. You see me on a Zoom every week and we have a chat. So what's included? There's 8 learning modules. It is very comprehensive. You get my expertise. You get 5 plus video lessons, plus menus and recipes, daily movement and coaching. So we have a movement accountability group where you'll be checking in every day. A continuous glucose monitor is included in the program as well. It's something that I think is a really nice hack. And we do this together so we can share our results and talk about possibly what's going on and how to change things. We do have a private group chat that everyone is invited to communicate in. You get 3 wonderful course handbooks. So one is Women of a Certain Age, the course handbook, and then Everything Hormone Guide, and then your guide to essential lab work. So those are 3 written, very, very comprehensive material. You get weekly Zoom meetings, you get 20% discount on supplements, and opportunity to work with me one-on-one at 30% off. Now, Chris, I've changed things, and maybe you saw my email this morning, I don't know. But I'm doing something different here. It is the first time that I have offered this particular course. So it's a beta course. I've offered many other courses before, but this is a beta. And I'm offering it for just $100. And basically what that's paying for is a continuous glucose monitor and some administration fees. Okay. So enrollment is limited to just 15 women. So I do ask a commitment from my women who are going to join. They need to engage in the community, engage in the movement group, read the course material, watch the videos, and join in on the Zoom calls or at least listen to the replays. And then at the end of the 8 weeks, this is really important to me. I will ask for one more thing. I would like for you to share with me the value that you received and what the course was worth to you in real terms. And then and only then, if someone wants to contribute anything more, then they do that. But the cost to get in is $100. So I'm going to be sending up a follow email with a recording of this and then some of the details and how you can find out more about the course and to enroll if you'd like. And feel free to offer it to other women. I do have space. It starts next Monday, which is September 22nd. So my vision is to help as many women as I can lead amazing, healthy, productive lives to the very end of their lifespan. I mean, that's just what it should be like. And to educate and empower them to be their own healthcare advocates, knowing what they need and how to ask for it. And I believe it can be done best with a strong community and with a healthcare or a health advocate, not healthcare, but a health advocate by your side. And I'm hoping it'll either be me or somebody else. I think we all need one. Before we leave, I just want to leave you with some resources that I have found really helpful. I've listed some books on the left-hand side. Sarah Godfrey, the hormone cure. It's hard to say that. Cure book. I think it's a little more technical than maybe some other books that you might find out there. Laura Brydon, I really like as well. If you're in perimenopause and menopause, it would be the Hormone Repair Manual. Dr. Felice Gersh, if you haven't discovered her yet, on YouTube, I highly recommend you find her. And then she's got a book called Menopause 50 Things You Need to Know. Podcasts in general, Dr. Mark Hyman's a good one. The Hormone Solution with Karen Martell is a great podcast. I mean, the guest she has, the knowledge that she has is really, really deep. And then Half My Age, not quite as deep, but she's got good stuff by Zora. And then YouTube favorites of Dr. Felice Gersh and Dr. Luis Newsome. And you might have some favorites of your own, but yes, Christine, you will be able to forward the recording. Yes, you will be. I don't know if you guys are still on. Yeah, I think you are. Okay. So yes, I am going to send you that recording. You should be able to forward the recording from there. Okay. So I am done basically. If you have any more questions or comments, please go ahead and put them in there. Just trying to think, is there anything else? I think we covered a lot of things that people have questions about. And again, I did mention that people, there are pharmaceutical drugs for almost everything that I mentioned that we experience. But again, we start moving into polypharma, and there's always risks with pharmaceuticals. And I think knowing the risks and the benefits, both, are really important of estrogen and progesterone and testosterone as well. So thank you, ladies, for being here. For those of you who could not make it, I hope you enjoy the recording. Here's to moving through this space in grace and vitality and a lot of joy. All right. Take care. You're very welcome. Bye-bye.